Let's do some POCUS admin. First scenario. What goes into building? Do you understand like what a workflow is? Okay, cool. So what are the things that you need for workflow?
So workflow, you need, as far as like infrastructure, besides like ultrasound, you need an ultrasound that hooks up to like a middleware, like something to store the images, you need some way to
Sorry.
order like the actual exam.
Cool. So image order, image storage.
Or image order, image storage, image interpretation.
Yes. Oh, yeah.
I believe that's it.
Yeah. Perfect. So image order, and then so the order is the easy part, right? So what do you need for the order?
I like an indication for it, and then, or you just need like a physician.
Even more basic than that. So what do you need to have in your system in order to put a POCUS order in? The ability to actually do ultrasound POCUS order, right?
What do you mean? Like literally just like an or like.
Yeah.
Yes.
Yeah. So who do you need to talk to?
Oh, you need to talk to like whoever. If you're doing it through that, you need to talk to like the vendor for the machine and then your middleware. And then if you have middleware and then also your, or for, no, back up, just the order.
Yeah.
It would be like whoever's the EMR.
Yeah, exactly. Yep. So you need the IT person for your EMR in order to get the order in the system.
Yeah.
The next part comes to your image storage. So there's a couple different options for image storage. Do you know what they are?
If there's like a physical copy,
Yep. So you can,
middleware, or just regular like system.
yeah, pretty much. So you can actually physically print a picture and save the picture. You can store it on the machine and export it from the machine onto like a hardware, like external drive, and just house that. You can send it to PACS or you can send it to some like third party. When it comes to image order, sorry, not image order, data entry onto the machine. Do you know the different ways you can do your data entry?
As far as, you mean like an order based or?
Yeah, exactly. So you can do it manually, right? That's sort of like our default, everyone goes order based. So that's where you put your order in first. And then you can pull up the patient list on that work list based on the order, or encounter based. For radiology, works off of order based. So you put the order in, it shows up on their list, and they get the patient. Ideally, for emergency medicine, encounter based is really the best way because it's basically everybody that's registered in the ED, and then you just go through the registration list, you find their name, and then you activate it. So you don't need an order. Yep, that's encounter based.
Okay.
It may work with Epic, but with Cerner and Butterfly, they could not get the encounter based to work. So if you have a middleware, you got to talk with your IT peoples to see if this is something that's an option, because that's what held up our deployment of Butterfly here was because we tried for 2 years to get the encounter based workflow to work, and it didn't. All right. So we got our image order, right? That's your PACS IT person, sorry, your EMR IT person. Your image storage, that's typically, if you don't have a workflow with like a third-party system, like a Butterfly or a QPath, most commonly image storage is gonna just go to PACS. That's kind of the easiest way to do it, as long as you're not overloading with educational studies.
Quick question on the encounter based. So then like the ways it's stored, usually like it would end up being like in a whatever exam. Like would it be like, oh, this is like Jane Doe's?
So it's basically, I think it's like ADT. So it's the list of patients that are registered in the ED.
Yeah.
Basically is what populates your ultrasound machine work list.
Yeah.
So that's where they're getting the feed from.
Yeah, and then you like end up just like clicking that page and opening it up and like saving those images and you're done. I'm just wondering like then like in the middleware or like the PACS system, because you know how like for us we can like click on it and it said like, or like we click on the radiology section, was it like point of care like echo? Like I wonder, does it say just like point of care ultrasound on like this date? Or
So that's what I don't know. So essentially our IT people could not get the images into Cerner because there wasn't an order, and they couldn't associate the images with the patient without an order. So it was something on IT speak that I don't understand. So yeah. Okay. And then the final part, right, is your image interpretation. So how are you going to get your image interpretation? Like, where are you putting it? And then are you getting it? So are you documenting it in the chart? And if you're putting it in the chart, is it as a procedure note? Is it within the chart itself, like under like the actual like MDM? And then if you're doing like educational scans for residents, do you want the residents documenting their ultrasound exam findings in the patient chart or as a procedure note, or do you want it housed externally from the medical record? If it's housed externally from the medical record, and obviously the workflow, like a third party, is an easy solution to that. But if you don't have it, what are other options you can use? Because you're going to need to be able to basically link the images to the interpretation so that you have the ability to QA. So this is something for you to
Yeah, no.
think about. What we did here before Butterfly was we used new innovations. So essentially the residents logged their interpretation with the patient information under new innovations, and then they were not linked in one system. So it was like PAC system and then new innovations, and we kind of cross-referenced between the two of them.
Yeah, I remember.
Yeah. Other things you can do is like Google Forms, although not HIPAA compliant, so we can't have any patient information. Microsoft Forms, you can do it that way as well. When I first got here, we were doing paper. So you essentially just did like a checklist of what your interpretation was, put the patient sticker on it and put it in a locked box. And then we would pull the data, the images off the machines that way.
Yeah.
So you kind of get creative. When it comes to wanting to do interpretations in the medical record, that's where you're going to have to also talk to your IT, your EMR IT people. Because the easiest way to do it is to build out some sort of like pre-check procedure note, where essentially you have your indication, the findings that are like you're specifically looking for, and then your interpretation. So again, that's one of the things you're going to need to know when you go elsewhere is who you need to talk to for the EMR IT, and then who's your PACS IT person. Those are going to be the two big parts for the workflow part of it. Just quick for the workflow, these are the three main ones. I think there's a fourth one that's starting to come through. I just don't know the name of it. QBath's been around for a really long time. I don't have any experience with it. Sonos Synchronicity is newer. This is like Fujifilm's and Sonosite's program. I can tell you, having gone through this, they make you sign a 5-year upfront contract, and the price quote they give you, at least that's how they did it a couple of years ago, was for the entire 5 years. So the price quote for like Synchronicity was $200,000, whereas Butterfly Enterprise ended up being like $15,000 for like the first year. And then the price kind of changes after that, but they only give you like 1 year at a time, and you don't have to sign that like 5-year contract. So we ended up going with Butterfly simply because it was a cost issue. Our IT people had, I guess, worked with QPath and Norwalk, and were like, absolutely not. They're horrendous. It does not communicate with Cerner well, and they had a lot of issues. So that was our experience. So we kind of by default went to Butterfly. Butterfly. It depends on per third-party probe. So any non-Butterfly device in the old system. So they have two different payment structures. We're on the grandfather, the old one. So we basically pay per device. So any Butterfly device, I think, is like $1,500 to get on their system.
But that's
That's just the Butterfly. Yep. Anything non-Butterfly, it's 3,600 a year plus a 3,000 initialization fee. So it's about 6,600 to get the devices on there.
And
So-
that ends up being just per device. Is there any?
Per device. Their newer payment structure is going to be per user. So you have an unlimited number of machines, but you're paying now for the user slots rather than the machine slots. Which I think is good for programs that have like only attendings and not like, 80 residents coming through. So for the price for us to go to per user to include every resident, it was like triple what we're paying right now. So it didn't work for us.
How'd you, I don't know if you're gonna talk about it. Could you justify it to the hospital?
Yeah, we're gonna talk about it. So just a quick how this workflow is, or this like middleware works. So essentially, most programs right now is you go into your EMR, right? You put your order in, you go to your machine, you'll pull up your work list, and you don't need a middleware to have the work list. That's something like your PACS IT people can just build for you. And the way our people do it is that they query anything that says ultrasound POC order gets put into a specific work list. And that's how and then that's what shows up on the ultrasound machine. So we don't see the radiology ultrasound studies. So that's definitely one of the things you need to clarify, because that took a little bit for our IT people to realize that ultrasound and POC were not the same thing. So make sure that like in the order, there's some distinction for POCUS versus radiology ultrasound. And then from the machine, usually DICOM is how it communicates, and it goes to PACS, and PACS is stored. The problem with this is that there's really not a great communication between PACS to EMR, which is what our issue was before we did our middleware.
Yeah.
So in order to view the images, you literally had to log into PACS outside of the patient's chart. You couldn't pull it in so there was no connection here. So essentially what the middleware does is you put the order in, it then connects to the machine puts it out to the middleware, and then from here, you can keep it as educational, meaning it never makes it into the patient chart, which is really good for like resident and learners. So you don't need to overload PACS with resident studies, because PACS storage costs money. It allows you to generate the report. So now you have your image interpretation, which then can go to your EMR, and you can link your images to that report, also easily viewable in now your EMR without having to log into PACS externally. The other really nice thing is it can help capture billing, because now you have CPT codes associated with your interpretations. You can use it to track provider numbers. So for resident numbers, to make sure they're hitting their graduation numbers, and then for providers who are privileged, to make sure that they're keeping up to date with their studies, and then those trying to get credentialed. Image review, so now you have your QA/QI right in there. And then the other nice thing is that you can access it remotely. So you don't need to be on campus. So the downside is expensive. So the way I had to do it was my initial request went through capital budget. So what you need to figure out is, when is capital open for requests? And generally you have to write up a proposal. So you need to get price quotes from the different vendors, and then you need to create a justification, and you need to be able to demonstrate some sort of return on investment. So if you're going to invest $15,000 into this, I'm going to be able to recoup the billing of XYZ ultrasounds. So essentially the way I proposed it was, we have 10 residents a year. Every resident has to do 150 ultrasounds for graduation. That's 1,500 ultrasounds. 10% of those may be billable studies. So essentially I'm losing, 150 scans per resident a year of revenue that the hospital can be generating. So you have to be able to demonstrate some sort of return on investment.
Yeah.
And then you can use it from like a safety standpoint for ease of QA. You can use it for monitoring credentialing and privileging, image review, that kind of stuff. And then for us here, the first purchase came out of capital, and then every year after that, it falls under an operational budget. So those are two separate working budgets. So just understanding that. The other thing is figuring out whose budget does this fall under. Because initially when we tried to push it through, we tried to push it through under PACS IT budget, and that was like, nope. We tried to push it through the ED budget, and nursing controls our ED budget, and nursing was like, I don't understand why we need this. We don't need it. So like they refused it. So we finally got it through under the GME budget. So right now our GME actually pays for the middleware. So that's sort of the way it works. So figuring out what line. The other thing I initially tried to do was I approached like anesthesia. I approached IM, I approached critical care and OBGYN, and saying like, we have this program that can store your ultrasounds. You can review them, you can bill for them, you can like use it for resident education. is this something that you want to buy in? I'll do all the work. I'll do all like everything you need to do. I just need like, if you're interested, I need your department to basically sign on and agree to give the funds or a portion of the funds. So I found it was a little bit easier when I was able to show that multiple programs would be using it as opposed to just the ED. But yeah, the biggest part is going to be getting price quotes. And then there's a lot of IT things that they wanted, like security, data builds and stuff. So that's like the largest part of admin. All right, next part is QA, QI. So QA is basically your image review. That's your quality assurance. And then QI is your feedback of your images. So QA, QI is going to build off of your workflow. So that's why it's really important to be able to link the images to the interpretation and to have them in a place where you can easily find the interpretations, where you're not logging into like every patient's chart, trying to scan through the EMR record and find the interpretation there, because that's like very labor intensive. So new innovations is really good for most residency programs if you're not going to have a middleware where you just have them log the scans and then there's your interpretation. So you're not logging into patients' actual charts.
Before innovation, did you have any QA process for like attendance?
We had paper. So they were supposed to like fill out a paper.
Was it used really think?
No.
But that's where I'm at. We have something called metrics, like same thing.
Mhm.
That's where like you can put patients on REN, like
Yep.
confidentials for exams. I was like, oh, this is perfect. Like I could just like format it.
Yeah.
Like how we initially did it here. But yeah, I was like, I don't know how to do.
That's the problem, is the attendings.
And then like if I'm pushing this whole thing, it's like this is gonna be billable.
Yep. So the other thing becomes, how many exams are you going to QA? So you can exam providers, so attendings who are credentialed, you can QA as little as 10% to no percent of their exams, because your argument is that they're credentialed and they have privileges and they've demonstrated proficiency, so I don't need to review their studies. Like they know what they're doing already. Versus resident exams, right? You want to be as close to 100% as possible. So it's kind of your decision. Again, the credential providers is going to just play off of the ease of being able to figure out like what scans are done solely by the attendings and not the residents. And then the other one is figuring out how you're giving feedback. So is it going to be in person, right, as like conference lectures and image review? Is it going to be via email? Are you going to be scanning with them in real time so you can do real-time feedback? Are you going to have them scan and then come and like present the images to you and then give feedback after? So that's one of the things. And then feedback of a credential provider versus non-credential provider. I don't think I put it in here, but also part of the feedback should be tracking their like true positive numbers, true negative numbers, false positive, false negatives. And then ideally having some sort of sensitivity and specificity for providers, so that this way, if they fall under like a 90% sensitivity specificity, they get flagged for like additional education needed. And then the other one is like tracking POCUS numbers. So with new innovations, it was kind of easy. You could just run a report at the end of the month or however often, whatever dates you wanted. And then it would just kind of spit out the number of POCUS exams that were done for residents. So that was kind of easy for your resident exams. Again, the attendings had to be kind of tracked if you're not in a middleware, a little bit harder. But if you set up some sort of like Microsoft Forms or Google Form and send out many emails of reminding people to fill out the information so that you can track their numbers. The other big one is discrepancies. So how do you handle discrepancies? So if they see so if they do a bladder exam and they call a mass a prostate, who's calling the patient back? Is it the provider? Is it you? How long do they have? What's your turnaround time for QA to catch these sort of discrepancies? And then does it go in the chart? Is it an addendum? That kind of thing. And then again, discrepancies with credential providers are always a little bit of a more important thing, right? Because those are in theory should be affecting their medical management, whereas resident exams are more for education, so they shouldn't be impacting clinical care. So a discrepancy with the resident exam that ideally did not impact clinical care is more so just like an informal email education, whereas a credential provider that, you know, measured the interior of the aorta and totally missed the AAA because they didn't measure outer to outer, right? It's going to be a much different approach. So having that sort of delineated. And when we talk about procedures, this one will be a big one in there. All right, all things to think about. You're like, oh.
So much in my mind.
I'm changing my mind. So the next one is ultrasound machine maintenance. So what do we think goes into the machine maintenance? And what stuff do you need?
Software.
Mm-hmm.
Software as far as like the machine, like making sure it's sending images over to the PACS system properly, it's getting the order properly. It's doing that, well, software wise. Like you're wiping the machine every now and then to like make sure the storage isn't like too built up.
Yeah.
Because of hardware, like kind of thing to do. They're clean, they're charging properly.
Yep.
PVs, you don't like cracks, like probes, wires aren't like frayed.
Good. And then what other kind of supplies do you need for an ultrasound program?
Gel.
Yep.
Some kind of sim. Something. Like if it's gonna be like true training, like sims, I even center, like you just like ultrasound. IV mannequins.
Yep. And you can,
back.
yeah, so gel nerve block needles, right? The echogenic needles. If you're gonna do it, I recommend trying to set it up correctly in the beginning rather than just being like, oh, we'll make do with like LP needles, because then you're never going to get your nerve block needles. And so if you can argue the safety is needed if we're going to be instituting this program. And then the correct wipes, right? So knowing what wipes are approved to clean the machines, right? We don't use the bleach wipes for the machine. So figuring out the brand that you have, and there's usually a list of pre-approved wipes. And then knowing who orders your supplies, right? So figuring out who that contact person is to get your nerve block needles, to make sure that you have enough gel, the long IV ultrasound needles, making sure that you have probe covers. Okay. You talked a bit about the connectivity. So knowing who your Biomed folks are, because they're the ones that's going to get you on the Wi-Fi, and they're going to do the actual physical repair of the machines. And then knowing, and then knowing the rep, so who to contact from the company to come in and do the software updates and then do any other like troubleshooting for you. So those are kind of like the big things to know. So know who does your stocking and ordering, know your PACS IT person and your Biomed person for the connectivity of the machines, and then know who the reps are for the repairs and troubleshooting. Here comes the fun part, buying new machines. So what kind of things do you think you need to get a new machine?
Stuff like pricing. You need pricing, you need to figure out like where the money's coming from.
Yeah.
Like,
So
like again, departmental.
Yeah.
Like hospital, contract medical group, is it educational?
Yep. And that goes into the justification, right? So knowing the billing cycle for your hospital, like for us, our capital requests are due in March. So knowing come, February is when you're going to have to start reaching out to ultrasound reps to get demos for machines and get quotes for a cost of machines. And then that's going to go into the amount of money you're going to request during your capital open period for capital requests, and then writing up a justification. So why do you need more machines? Trying to demonstrate some sort of return on investment of you buy me this $50,000 machine and I will be able to generate $80,000 in ultrasound billing for you. And then the nitty gritty of purchasing who fills out your capital request forms, right? There's a whole bunch of like cost center codes and a lot of other details that have to go into it that should not be your job. Like, do not take that on. That is not your job. Find somebody to do it for you. If it's GME, then it's usually who's ever the program manager that the ultrasound is going to fall under, which is typically EM. If it's through the ED department, then it's going to be the person who does the ED restocking. They're going to be the one that's going to be doing the filling that out for the purchasing. And then after purchasing, right, the machine setup. So whose name is going to be on the delivery address for the machine? Do you need to contact receiving to know that a machine is coming? Who's like coordinating the tracking number so that you know it's coming? Who makes sure that it's going to Biomed, right? Who's going to send it from receiving to Biomed? Does biomedical engineering know how to set it up, what Wi-Fi it needs to get to, how to connect it to PACS, how to connect it to the workflow? So all of this goes into getting a new machine as well. And then other things that goes into buying a new machine is, does your hospital have a current contract with specific ultrasound groups? So you may only be limited to Sonosite or GE. You may not be able to go outside of that. Other thing is discounts. So if you are ordering multiple machines at once, so if ICU needs a machine and ED needs a machine and anesthesia wants the machine, you might get a better discount by going through the same company and ordering 3 of the same machines versus I order a GE, they order a Mindray, and they get a Sonosite. Other discounts is a lot of the programs have med ed discounts. So for GME and training programs. So make sure that you're inquiring, because Sonosite, without the discount, it's usually like $80,000. With the discount, you can get about 50,000. So most machines you can get with some sort of educational discount around 50,000, 50 to 60. And then knowing your compatibility. So can the machine send and talk to your PACS and your EMR system is also going to be an issue. And then providers' comfort, right? People get very upset when you start like changing up their ultrasound machine. So if everyone's used to like a GE and now you bring in a Mindray, you're going to get some pushback. I got a lot of pushback from bringing in Philips for like the Spark, and the ICU got some handhelds from Philips, and like I'm still not hearing the end of how much like everybody does not like the Philips. So knowing comfort levels and things like that. The other thing is cart machine versus a laptop machine versus a handheld. So what is your budget? Cart machines are going to be the most expensive. So those are going to be like the nice big fancy displays, but those are going to be better for education. Your laptops are going to be a smaller footprint, better for clinical use. And then handhelds are going to be your cheapest option, but really not as great image detail. But, there's studies out there showing that your information that you can get from a handheld is accurate compared to like a cart machine. So also knowing what your budget is going to house and be able to handle which one. Infection control. Do you understand the difference between cleaning and disinfection? Okay, well, what's cleaning?
Surface, just.
Yeah, so just wiping off the dirty stuff that you see.
Yeah.
Versus disinfection, which is basically destruction of pathogens. Yeah. Cool. So there's different types of infection control based on the type of ultrasound. So you have non-critical devices. So this is essentially like 99% of what we do in scanning. So this is intact skin that you're using a probe for. You have your semi-critical devices. So these touch either non-intact skin or mucous membrane. So these are like your transvaginal scans or your TEs. And then critical devices is not DED, but this is essentially sterile tissue or intravascular. So these are like your like esophageal ultrasounds that they do. This is like your intracardiac ultrasounds for the lumens and stuff like that. All right, so now you have cleaning. So do you understand the difference between low level, intermediate, and high level disinfection?
Like I know like high levels. The trophon.
Yep, perfect. Yep.
It's just like.
Kind of, yeah. So the difference between low level and intermediate is essentially one kills TB and one doesn't. So low level does not include TB, whereas intermediate level does. Most of the wipes that we use, like the Oxivir, the gray top wipes, the hydrogen peroxide, those are all include TB. So those are intermediate level. Your Trophon, like you said, this is high level disinfection. So, whoops. So essentially your critical devices fall under high level. Your semi-critical devices typically fall under intermediate. The exception is your transvaginal probes, which have to have high level disinfection. So if you're going to have TB probes, you have to have Trophons.
Yeah.
And then I didn't get into it, but the ED itself can buy a Trophon, or you can pair with your radiology department and see if they'll clean your stuff for you. And then non-critical devices are basically low-level disinfection. All right. You're supposed to clean it. So if it's contaminated, so you're scanning, say, a fast exam, and there's blood on their skin, you should put a cover on it. And if the cover breaks, this should have at least intermediate level disinfection. If it's an intracavitary probe, it needs both a cover and the high level disinfection. If you're doing a procedure, you should have a cover and a minimum of low level disinfection. So a cover and a wipe. And then everything else, essentially 99% of what we do would just be low level disinfection. All right, billing. So what do we need for billing? We kind of talked about, you need your order, right? You need your documentation, and then you need your storage. The alternative way to bill now, so this way is very nice and neat, and it's easy to essentially go back to your hospital or your company and run a report of everything you billed and then what's been generated from our bill. Now with the update, you can also bill through your MDM, where you don't need the order and you don't need image storage, you just need the indication and the findings. The problem with this is that it's very hard to show the return on investment of ultrasound, because there's no good way to capture your ultrasound in here and see if that increased your MDM and let you bill out at a higher level. But there are two ways. If you have to build worksheets from scratch, ASAP from 2018 has ultrasound standard reporting guidelines. And so essentially they have, this one for abdominal aorta, they've got your indications, they've got your views, and then your findings. So this is sort of a nice thing that you can bill off of. Talk to your billing company and make sure that the documentation that you have is what they need. Because sometimes if it's too simple, a lot of the companies will, like the insurance companies will refuse it. Yes, YouTube video. This is an hour-long lecture from Scuff, or not Scuff, from Surf for billing. So definitely review that, especially for you, super important. Know that for us, the 26 modifier is the professional component. I believe the 52 modifier is the technical component. So you'll get a total payment of, like, say this is for a fast, so you get $320. 80% goes to the hospital or those who own the ultrasound machine.
That's on the board.
Yep. And then 20% goes to like the ED as the professional payment. Some legal issues. If you're going to start billing for them, you got to make sure that you absolutely have your documentation, that you have your image storage. You might have to talk with risk management, because now you're setting up an area of liability for discrepancies. You have to make sure your policies are in place. The other thing is you need to save images for at least 7 years and allow time for discovery. So if at the 6 years and 351 days they pull the case or the file, you now have to have those images for an extended period of time to allow for that sort of discovery. The other really important thing is if you're scanning kids, right? Kids are up to age 18. So if they scan a newborn and they miss pyloric stenosis, right, that case can be discoverable up to age 18. So knowing that information.
For billing, like, have you been in contact with hospital billing or
Both.
team health billing?
Both.
Okay.
Yep. And they need to talk to each other as well. Here, we actually, the way the billing structure is set up, it's a bundled payment based on what coding level Team Health bills it at. So if Team Health bills it as like a level 3.
Yeah.
The hospital actually doesn't get any extra money for the ultrasound because it's bundled into the payment.
Oh, really? Then
Yeah.
why not?
It's the way the contract was arranged back in the day. So for me, it made it really hard to demonstrate return on investment because I'm like, oh, we bill and we can get all this money. And the hospital is like, yeah, but we don't. It's just bundled into like whatever we get. So it's not an extra payment that they receive.
Yeah.
So knowing that information is also really important. Okay, policies. These are super important for you to have. So having some sort of policy talking about privacy and confidentiality, basically just saying that your documentation, interpretation, image storage is on HIPAA compliance servers, that anything that is sent over via email includes PHI, is sent under a confidential email heading. Quality assurance, right? How often are you doing it? Are you QAing 100% of exams, sampling 10% of exams? And then what your quality assurance looks like. This is the standard, right? The grades 1 through 5. And then again, tracking your true negatives and true positives for your providers. Again, we went into this already, but your discrepancy policy. So having that, having infection control policy, talking about high level, intermediate, low level, disinfection, what gets cleaned with how. Credentialing and privileging. So you're also going to be now responsible for 2 training pathways. So you have people who are trained with residency and then people who were experiential learners who basically got on the job training after residency. So these are generally like your greater than 10-year practice people. These are your less than 10-year practice people. And then figuring out what your training volumes are going to be. So people who need to get credentialed, meaning the first time they're going through the system. Most of the time it's 25 to 50 exams that they have to complete. If it's like a transabdominal versus transvaginal, usually it's just like 10 so they need 10 transabdominal and then 10 transvaginal to get credentialed. Knowing what percentage have to be abnormal. So most places use 10% as abnormal, but ACEP, ABEM, I think, just says significant abnormalities. Actually, ACEP says significant abnormalities. Significant percentage have to have abnormalities, but doesn't give you a number. And then there's a lot of data now that's trying to actually move away from numbers into more of a ability. So if you can demonstrate in 5 scans that you know what you're doing versus somebody who's gone 50 scans and still doesn't know what they're doing. And then supervision. So what kind of supervision are residents going to get versus credentialed providers versus those who are obtaining privileges. And then finally, your job. So having some sort of policy that delineates what your responsibilities are also important. And then finally, collaboration. So getting on board of cardiology, you don't want to piss them off because they're, at least here, they're quite strong and they can easily put a kibosh on stuff. So letting them know like what you're doing, that you're not stepping on their toes, you're not billing if they're going to be billing for echoes. Trauma, if you're going to be doing partnering with them for their FAST exams because they need those for their accreditation. And then anesthesia, ortho, and trauma if you're going to be doing any sort of nerve blocks. So making sure that they're involved. I think that's all I have.